Just as we were a little distracted with another article, an international team wrote the 2024 Hypertension Guidelines for the European Society of Cardiology. Here is a brief overview. As expected, they build on the prior guidelines and adjust to the newer scientific evidence.
Emphasis is made, among others, on cardiovascular outcomes, patient-centered care, measuring blood pressure accurately, self-measuring of blood pressure, communicating the consequences of treatment of hypertension. The new guidelines defines blood pressure ranges differently: non-elevated blood pressure, elevated blood pressure, and hypertension. Blood pressure between 120 to 139 systolic and or 70 to 89 diastolic is defined now as elevated blood pressure. The other two classes are below or above, respectively. The goal range for treatment for hypertension is 120 to 129 systolic.
In general, if the patient has a blood pressure greater than 130/80, after 3 months of lifestyle modifications, then start medication treatment. But, if the blood pressure is greater than 140/90, then initiate both lifestyle modifications and medication treatment, irrespective of cardiovascular status risk. Also, there is more emphasis in out-of-office blood pressure recordings, using a calibrated device to guide the long-term treatment. They state that home blood pressure measurements be used, if possible, to achieve better blood pressure control.
More recommendations include regular exercise of 150 or more minutes per week, if less than that, then complement with dynamic and/or isometric exercises. Aim for a BMI between 20 and 25. Aim for a waist circumference of less than 94 cm for men, and less than 80 for women. Emphasis the Mediterranean or DASH diets. There is recommendation to use a combination of 75% sodium chloride and 25% potassium chloride salt substitute, instead of 100% sodium chloride, when the renal function is preserved. They recommend to discourage consumption of sugar-sweetened drinks and fruit juices starting at young age.
It is important to risk stratify the patient, such as with the SCORE2 tool. They indicate that severe mental illness could be used as an up-classifier. In patients under 40 and with obesity, a recommendation to start with evaluation for sleep apnea is given. The first line of medications include ACE inhibitors, angiotensin receptor blocking agents, dihydropyridine calcium channel blockers, or thiazide family medications. In patients with CKD, they encourage to consider the use of sodium glucose transporter 2 inhibitors.
Recommends performing orthostatic vitals on patients, at initial diagnosis, at initiation of treatment, on intensification of treatment, or if certain conditions are encountered, for example, suspicion for primary aldosteronism. A drop of more than 20 mm of mercury on the systolic blood pressure, or greater than 10 mm of mercury in diastolic blood pressure, considered positive, after 1 or 3 minutes of standing. The guidelines further define the procedure for taking the orthostatic vital signs. In patients with renal artery stenosis between 70 and 99%, consider artery angioplasty without stent. Further, the 2024 European Guidelines introduced the use of catheter-based renal denervation procedure for patients with difficult to control blood pressure. The procedure is to be performed in centers with medium to high volume expertise. They do not recommend it as a first or second line approach. The decision to perform the procedure is shared with the patient.
The guidelines warns on the risks blood pressure that could be too low to be symptomatic. They point out special consideration for certain high-risk groups and pregnant patients. Also, emphasizes caution on overtreatment, especially in moderate to severe frailty, older, and/or with limited life expectancy individuals. In such cases, a more lenient approach may be considered. They mention the use of the Alera principle, or as low as reasonably achievable principle.
In patients with intracerebral hemorrhage, presenting with systolic blood pressure greater than 220, they warn about lowering the systolic blood pressure greater than 70 mm of mercury too soon, or too fast. In patient with acute intracerebral hemorrhage, lowering the systolic blood pressure to 140 to 160 within 6 hours is indicated to decrease the risk of expansions of the hematoma and improve functional outcome.
Keep doing and expanding on the amazing work you do. There is more to learn from the 2024 Hypertension Guidelines. The link is in the description below. Thank you.